What is the volume status of this patient? That is a very complicated question where actually ultrasound can help you to answer this question very often. Fortunately, we can use several loops, videos, images, and imaging modalities. Here, for example, ultrasound of the jugular vein, TE studies, TTE studies, Doppler studies, and many, many more to figure out what actually volume status of our patients is. Starting with the volume management with ultrasound, it's crucial to understand, it's always to differentiate, is this patient really dry as the desert? Is this patient wet like a watered poodle? Or is it about the heart, the lungs, and many more things, and not always that easy? Overall, patients with severe hypervolemia or hypovolemia always find the way to an emergency department and further on to intensive care treatment. Initially, I want to discuss B-lines. So B-lines are reverberation artifacts. They always originate from a smooth pearl line. They are echogenic, so hypoechoic. They do not fade until the end of the screen, depending on where you still see B-mode imaging. They always move with lung sliding. They do not fade. They cover other artifacts such as A-lines, and they are a sign of free lung water. I want to emphasize it really has to be a smooth pearl line to call the artifacts B-lines. The first patient we are discussing is George. George presents to the emergency department with severe dyspnea. It was overall relatively quickly progressive at home. He is in the ER. He moves to the intermediate care unit where I see the patient first, and initially the patient has severe dysentachypnea. The suspected diagnosis from the emergency department is pneumonia, and there he got 500 milliliters of a crystalloid. His oxygen saturation, even with oxygen, is really bad, approximately 70 to 80%, and the recommendation from the emergency department is this patient most likely needs to be intubated. Well, let's take a look and figure out, is this patient really dry, and is the dyspnea because of his pneumonia, the initial diagnosis we reported, or is he really congested? Let's take a look at the lungs. And when we look at the lungs, so this is the right side, this is the left side. Here the R is simply wrong, so you can also, depending on your machine, write the various zones you are scanning. And in this case, you have your rib shadows, and in between the rib spaces there's the smooth pearl line. You have plenty of artifacts, so many B-lines. That's a so-called white lung. On the left side you see a similar image, a lot of B-lines. So does this patient have enough volume, or do we even need more volume to save this patient's life even? Well, of course, when you see a lot of B-lines, this is congestion. This is actually a case of pulmonary edema, so massive B-lines. Everywhere you have the smooth pearl line, the reverberation artifacts on both sides, left and right, is very indicative that this patient has a problem with congestion. Moving on to echocardiography. So when you are scanning the lungs, you always should scan the heart, at least to a certain degree, to figure out, is the severe left or right ventricular dysfunction present? Are there wall motion abnormalities, as in this case? Is there a truly reduced ejection fraction or truly reduced ventricular function present? In this case, yes, ejection fraction was severely reduced, around 30%. And George, in combination with those two, we did see the problem with the left ventricle, and we did see a lot of B-lines, and we also did talk to the patient, of course, and he had no signs of infection. He said, I just felt severe dyspnea and tachypnea. I never had a diagnosis of a heart disease before. I have hypertension. He has also diabetes. He didn't say that he ever complained of severe chest pain, but most importantly also his blood pressure was very high when we had invasive measurement. So no more water for George, this is pulmonary edema. And it's very nice with therapy, so with diuretics, nitroglycerin, and CPAP, so non-invasive ventilation. Very quickly you do see that this is the pearl line. There are still some artifacts present, but you see other artifacts as well, so-called A-lines, the mirror artifacts of the pleural line, indicating that there is less free lung water present. The same is on the left side, you see it over here, and you see A lines and definitely less B lines. And also our patient was feeling much better just briefly after we initiated therapy. So comparing before and after, so this is before treatment, this is after treatment. Here you have plenty of B lines, here you have singular B lines. So this is a case of pulmonary edema due to the high blood pressure and due to the reduction in left ventricular function. So what about George? George definitely doesn't need more volume. We have a new onset of heart failure with reduced ejection fraction with wall motion abnormalities indicating coronary artery disease. We have massive B lines which are improving with therapy. We have a dyspneic patient who again feels very, very quickly way better after initiation of therapy, and a hypertensive patient. Also that of course was treated, so a hypertension-induced pulmonary edema, and this initial diagnosis of heart failure with reduced ejection fraction on the intermediate care unit. Of course, George has to find his way to a specialized cardiological workup, but in the initial state, in the critical state, George needed a quick diagnosis because this was a potentially life-threatening pathology. Going to another patient, it's Victor. Victor is 79 years old and he's a farmer. Now we are scanning Victor. We have several views at hand, and you can go back to the compact echo course to see how all those views are acquired. And in this case, we see something different. We do see here the liver. This is now a visualization from a subcostal approach of the IVC. The IVC is collapsing. You can see it in B mode imaging. You can also see it with M mode. I prefer personally the B mode imaging, as you can really see it way better. But it was not even that easy to keep the IVC in our field of view, but when you take a look at the internal jugular vein, you see that it's also collapsing. And here this is a placement of a needle for a central venous access. You also do see the collapsing internal jugular vein. So what's the problem of this patient? Is he really dry, or is congestion the problem? Well, this is a case of severe hypovolemia. He was a farmer, and dialect, I'm normally speaking, it's Corinthian dialect, it's called Heigen, so it's harvesting hay. It was summer, he had a cold, he was wearing then a jacket, he went home, and he actually fell asleep below the sun. He was admitted with hypothermia. We measured 42 degrees of Celsius, which equals 108 degrees Fahrenheit, so severe hypovolemia due to hypothermia. How can we differentiate? To wrap it up for now, the IVC gives important clues, especially if it's collapsing entirely, if it's really small, if it's collapsing entirely. Plus, in the previous case we had a history, we have a clear answer. This is most likely not hypovolemia, but if it's collapsing entirely, if it's very, very small, it's hypovolemia. Depending on the IVC diameter, if it is above or below 21 millimeters, or equaling 21 millimeters, and the collapsibility, we assume right atrial pressures. So if it is normal collapsible and the diameter is not exceeding 20 millimeters, the right atrial pressure will be in between 3 to 5 millimeters of mercury. We mostly say then 3 millimeters of mercury. If the diameter is above 21 millimeters and below 50%, then right atrial pressure is in the range of 10 to 20 millimeters of mercury. Everything in between you can count as 8 millimeters of mercury, and actually there is no reliable upper border. So in case of a dilated, non-collapsible inferior vena cava, we are just roughly estimating the pressures, and that leads to the next very important point. So this cutoff of 21 millimeters and the collapsibility, and if it's not a really clear case of, for example, hypovolemia, it has plenty of limitations. What you can use is a transverse approach. So not only the longitudinal approach of the IVC, but also a transverse approach. If you see a round IVC with no collapsibility, it also points towards hypovolemia or elevation of right atrial filling pressures. If it is oval and nicely collapsible, it points to euvolemia. But again, this is not the only vessel or the only view we need. We need more information. We of course need the clinical findings. This is utterly important. And we can take a look at jugular veins. We can take a look at the heart. So we can get and gather a lot of additional information. In echocardiography, as we have seen before, we have a reduced ejection fraction plus with lung ultrasound massive B lines that also leads to a clear answer. There are some pitfalls, for example, in a patient with ARDS. So if you have skipped areas, for example, so you should scan more areas of the lung, that can be a pitfall. So also keep in mind that there are distinct differential diagnoses in evaluation of the heart and the lungs.